We're excited to have Dr. Jordon Lipton and Dr. Beth Perry, co-founders of Signature Healthcare, join us today. Let me make some introductions. Dr. Lipton earned his medical degree at McGill University in Montreal, Canada, and completed his residency at Carolinas Medical Center. He is board certified in both emergency and ambulatory medicine and co-founded Signature Healthcare in 2003. He has contributed to numerous medical journals and textbooks and has lectured internationally. He is the Medical Advisory Board Director and a volunteer at the Heart Bright Foundation and a member of the Physicians Advisory Council. He has been featured in Charlotte Business Journal's Big Ideas profile, and Dr. Lipton and his wife have 2 grown children, enjoy squash, both the sport and the vegetable, skiing, art, reading, cooking, and travel. Dr. Beth Perry, she earned her medical degree at the Medical College of Virginia, completed a residency in internal medicine at the University of Pennsylvania, and completed a second residency in emergency medicine at Johns Hopkins Hospital. Perry co-founded Signature, the area's first concierge medical practice, in 2003. In addition to volunteering at the Heart Bright Foundation and participating in various nonprofit organizations and boards, she was the chairperson for the Health Service Committee of the Charlotte Chamber of Commerce for 2006-07 year. She is the past recipient of the Charlotte Business Journal's Women in Business Achievement Award. Dr. Perry was chosen by Charlotte Magazine as a top doctor in 2017, and she and her husband have 3 children and enjoy outdoor activities as well as travel. It is my pleasure to introduce Dr. Lipton and Dr. Perry.
Well, good afternoon. Thanks, Donna and FinTrust, for including us in this webinar. I'm Jordon Lipton, and I appreciate the very kind introduction. I'm going to speak briefly about concierge medicine and changes in healthcare as a result of the pandemic. And then Beth will discuss COVID testing and vaccines, which of course are constantly moving targets. And then we're glad to entertain any questions after we've finished. So for those of you unfamiliar with the term, concierge medicine is a relationship between a patient and usually a primary care doctor, in which the patient pays an annual fee in exchange for their doctor providing enhanced services, including a limitation of patient numbers, so that ensures time and availability for every patient. It is also referred to as retainer-based medicine, membership medicine, and in some cases, direct primary care. Most of these types of practices share some similarities, but can vary widely in their structure, their payment, and their operations. So Signature Healthcare has been in operation since 2003, and we offer a very high staff-to-patient ratio and thus much more individualized care with a focus on prevention as opposed to just reaction. We offer a 24-hour physician access, same or next day appointments that are on time, comprehensive in-office services with lab and x-ray included, and complimentary telephone care long before the COVID pandemic. We have 2 spa-like offices, one of which is uptown and one of which is in South Park. The uptown office, of course, due to the pandemic, is not open all the time because most of our uptown clientele are not working from their offices uptown. And because we're not owned by a large hospital system or conglomerate, we can always provide unbiased referrals to specialists and are able to hire the most talented and highly trained staff. And this is very much unlike the current trend in healthcare. We do accept insurance for the usual healthcare costs, but the membership fee itself is not usually covered by insurance. So how will healthcare look now that we've experienced a disruption in our current system due to COVID? First, we've already seen how telehealth or virtual visits have experienced a surge in usage in practices where practices and patients felt uncomfortable meeting in person. The technology has actually been here for several years, and it's very useful for several types of visits, but unfortunately, a virtual exam has definite limitations. We've been doing, as I mentioned, complimentary virtual telephone visits for appropriate use for many years. So this really hasn't changed for us, although it's become more widespread in the general healthcare community. Another trend that started prior to COVID is the use of wearable healthcare technology. This is also very useful for monitoring things such as the heart, sleep, blood sugar, and pulse oximetry and that sort of thing. And I think this is a great development, and I think very useful. And COVID, or the pandemic, has put this at the forefront. Due to the supply chain disruption that we experienced, especially at the beginning of the pandemic, we may find that more of our medical supply manufacturing will be occurring in the United States rather than elsewhere, and this will hopefully be a positive development. As a result of the significant toll that SARS-CoV-2 took on nursing home and assisted care facility residents, we anticipate that more people will opt for in-home care in the future. As you can see, the cost of nursing homes is quite expensive, whereas in-home care is actually less expensive and allows patients and family to have their loved ones at home. An interesting development in hospital medicine during the pandemic was the concept of virtual hospitalizations. Unfortunately, it's done little to reduce the cost of healthcare, but it does allow less ill individuals to be monitored remotely in the comfort of their own homes, and in some cases using wearable technology that I mentioned. If we can go on to the next slide, sorry. There we go. Much of this monitoring and the associated medical decision making has been handled by nurses and mid-level providers rather than by physicians. And interestingly enough, a Wall Street Journal article recently discussed how some healthcare corporations are moving in the direction of having teams rather than doctors and nurses care for groups of people, sometimes without any physician and often remotely. Unfortunately, this can result in further weakening of relationships between individual patients and their own doctors. And this brings me to the last of the known consequences of the pandemic, which is that more people have become interested and are enrolling in practices such as ours because they've been missing out on what we, the Marcus Welby type doctor-patient relationship. Where we have a single point of contact, a true doctor-patient relationship, a clean, low volume and safe environment, and more of a focus on prevention than in other primary care practices. And I think, of course, from our perspective, this is one of the greatest developments. And even though we did see a tremendous drop in office visits at the beginning of the pandemic, especially, we've noticed that many more people are deciding to proceed with membership because of the pandemic. So with that, I will hand over the microphone to Beth and then be ready for questions after she's finished.
Okay, welcome everybody. Thanks for taking the time to participate. So I'm going to talk a little bit about COVID, which is, obviously a rapidly changing situation. Jordon, can you guys hear me okay?
Yes.
Okay, just wanted to make sure that my microphone was loud enough. Okay, so, everybody reads the papers, and unfortunately there are a lot of conflicting information about what's going on with COVID, but I think the fact of the matter is that it's not going anywhere anytime soon. So we are going to be living under this sort of cloud of COVID, I think, honestly, until there is a vaccine that comes out. And the key, I think, to managing the COVID pandemic is going to be to try to diagnose as many people as possible so that you can isolate them and do contact tracing to figure out who they might have infected. So testing has actually been on the decline since July, and I don't know that anybody really knows why that is, but that may be because the number of cases had sort of dropped off a little bit in July, but now, of course, we've seen an uptick since Labor Day, and that is likely due to kids going back to school and the Labor Day holiday. But testing is critical to the mission to try to contain the COVID pandemic. And as a country, we did not do well rolling out testing in March, which is very unfortunate. So we are a little bit still sort of behind the 8 ball, I feel like, in terms of testing strategies. But the lay of the landscape in testing has changed dramatically even since July. And really, more and more companies are coming online with testing and getting emergency use authorization from the FDA. So literally the testing landscape changes almost on a weekly basis. And there are a lot more testing options available than there were 6 months ago. But by far, the most accurate test is the nasopharyngeal swab for PCR testing. Unfortunately, that is an expensive test, which is time consuming. And if you haven't had one before, it's really quite obnoxious. We refer to it as the brain biopsy because that's really what it feels like. The downside to this, it's the most accurate test, but the problem is you need a fancy piece of equipment in a big lab to be able to run this test. So most of the time when that swab is being obtained somewhere, if you go to a drive-up testing center or your doctor's office, or even in our office, we have to send that swab somewhere else to be tested. And the testing process actually takes a while. So it takes longer to get those results. In our office, we have relatively rapid turnaround time for this PCR testing in that we get it back in about 36 hours, which is pretty quick. When testing first came out in March, we had people waiting 5 and 6 days. And we saw that same thing in July when there was a huge demand for testing. So the nasopharyngeal swab is the gold standard, but it is not readily accessible. And because of the turnaround time being slow, it's not an optimal way to control the pandemic. Saliva testing has been around for about maybe 3 months. And the first test was developed at Yale, developed at Rutgers, but in conjunction with a study done at Yale that showed that it is as accurate as the nasal swab and a lot less pleasant. Plus, trust me, I've done both, and I would much rather spit in a little tube than have a brain biopsy. The problem is this technology is also expensive. It requires the same elaborate equipment as the nasopharyngeal swab. You're just getting the sample from a different place. You're getting it from the mouth instead of the nose. And there's only one lab right now because the test was originally patented by Rutgers University. And so they're the only lab that can run that particular test. However, and the NBA Players Association partnered with Yale to basically come up with their own test. They can't use the one from Rutgers because it's patented, but they created their own test, and it's called Saliva Direct. And they open sourced that. And what that means is they shared the recipe, so to speak, for how to run that test with anybody who wants it. And as a result, the cost is not very high. So it's a much less expensive test because Yale and the NBA Players Association are basically doing this to benefit society, not to make money. And so that technology is still being developed. The problem is you still need the lab. You still need the fancy lab. The issue is that Yale, that Saliva Direct, they give you the recipe. And Jordon had alluded to this. There's been some supply chain issues. For example, in July, there was a shortage of cotton swabs that we use to do the nasopharyngeal swab. These tests all require reagents to extract the DNA from the swab, and there was a shortage of reagents. And so the advantage to the Saliva Direct test is they give you a list of like 5 different reagents. Like if you don't have the first one, you can use the second one. If you don't have the second one, you can use the third one. So it is a little bit more broadly useful, but still tied to the expensive technology in a big lab. What we need to fine tune is what we call point of care testing. And the analogy there would be like a home pregnancy test. We would love to have a reliable, fast, accurate test that can be done in the field. So you could do it at an airport or at a school or at a football game and test people that way. And these tests tend to be a little bit less accurate. They are definitely faster and they can be cheaper, but they are still not ready for prime time. The Abbott Labs has developed a point of care test, which takes about 15 minutes, which is reasonably accurate. It's very, very similar to a pregnancy test. It does not require fancy lab equipment. It does not require reagents. The problem is the government snapped it up. So we were actually hoping to get access to some of those test kits, but the U.S. government purchased all 50 million of the test kits that Abbott purports to be able to develop or to produce in the rest of 2019 to be used in schools or wherever they see fit. So unfortunately, that seems like a really good test, but we can't get it because the government snapped it up. But again, research is ongoing. There are multiple labs working on rapid, accurate, inexpensive alternatives. And in a perfect world, we would have a test that you could buy at Walgreens and it would cost you, I don't know, $10 or something. And you could test yourself every single day if you wanted to, because that's, again, the way that we're going to control this pandemic is by identifying the positive cases and isolating them so that they can't infect other people. Unfortunately, we don't know the exact numbers, but unfortunately, a significant number of people who have COVID are probably asymptomatic. And so that could be 20%, it could be 30%. And if you don't know you have it, then you can't isolate yourself and prevent spreading it, which comes down to mask wearing. If we all pretend like everybody has COVID and behave appropriately in terms of wearing masks, washing our hands, avoiding congregating in large groups, that's the way the disease is going to be controlled while we're waiting for the vaccine, which I'll come to in just a minute. We've had a lot of questions about antibody testing. And what antibodies do is they tell you if you've already had the infection. There are two antibodies, main antibodies that are produced in caused by a viral infection. One is an IgM as in Mary. That's the first one. It takes 3 to 5 days after the onset of the infection to detect that in the bloodstream, though. So that doesn't help you because I could have COVID today and have a negative antibody test, but I still have it. And then there's an IgG, which takes 10 to 14 days to develop and lasts in your body for a couple of months. So if I had COVID in July and didn't get tested, you could test my blood for antibodies and find out that I had a past COVID infection. What we don't know right now is, does that mean that you're protected against future infections? Now, it's true that with most viral infections, you do have some lasting immunity, but what we don't know is for how long. Some viruses cause lifelong immunity. For example, measles is a good example of that. People who had measles in childhood are, immune for the rest of their lives. What we've seen with the other coronaviruses, though, which are SARS and MERS, is that the patients who recovered from those illnesses really only had immunity for a year or two. So we don't know what's going to happen with this unique coronavirus just because we don't have any experience with it. But the take-home message is antibody testing is interesting, but it's not really helpful in the acute setting. So now we'll go on to the next slide and we'll talk a little bit about the vaccine. I think everybody's heard about herd immunity and that in order for a disease to stop spreading in a population, you really need for 60 to 70% of the population to be immune to it. And that's basically the virus can't infect them, so they can't spread it to other people. And so while herd immunity would be a nice thing, it's not the way to get us out of this coronavirus pandemic without killing, millions more people worldwide. So what we really need is a vaccine. And there are multiple vaccines. And this also changes on a regular basis. So, the information that I used when I made this slide 2 weeks ago is almost a little bit obsolete, but there are probably about 20 different vaccine candidates being worked on worldwide. In my opinion, the three leading contenders are the Moderna vaccine, which is being made in the US. And vaccines go through phase 1, 2, and 3 clinical trials before they can get FDA approval for effectiveness and safety. And so, typically we've all heard this. Typically, it takes years to develop a vaccine, and so obviously everybody's going flat out to try to develop vaccines as quickly as possible for this coronavirus. And so, but the Moderna vaccine is one of the ones that is the most advanced. So it's in phase 3 clinical trials, and I have seen estimates that Moderna could produce maybe up to 1 billion doses per year starting in 2021. But the thing is, it's a 2-dose series. And most of these vaccines are 2-dose series given about 28 days apart. So, 1 billion vaccines sounds like a lot of vaccines, but then you have to divide that number in half because everybody needs 2. The AstraZeneca vaccine, which is being developed at Oxford in the UK, that's also in phase 3. And they are also trying to get 1 billion doses available in the next couple of months. That's also a 2-dose series. After I made this slide, that was the vaccine where they halted the clinical trial for a period of time because a patient developed transverse myelitis, which is we hope, temporary paralysis in the spinal cord, which can be associated with viral infections. And the trials have resumed in the UK and some other countries, but last I heard, it has not resumed in the US because they are, there are some safety concerns there. So that may be a hurdle for this vaccine. And then Pfizer is working on a vaccine in Germany, which is in late phase 2 to early phase 3 clinical trials. And they might have 100 million doses by the end of the year, but that's also a 2-dose series. So if you're talking about, the population of the world, which is on the order of 7 billion, it's going to take a long time to get 60% of those people vaccinated, which is why I don't think the vaccine is going to be the solution. Johnson & Johnson is also working on a vaccine, but they're in the much earlier stages. They're not likely to have anything until later next year. And there's also a Novavax vaccine, which is also in the earlier phases. So those are not going to be contenders for release in the near future. And then for the more adventurous set, if you wanted to go to China and get a vaccine, the Chinese government has 3 or 4 different vaccines in trial. And of course, we've all read probably that the Russians actually started mass vaccinating before they tested their vaccine for effectiveness or safety. So if you're in a hurry to get a vaccine, you could probably fly to Moscow and get one. So that's basically the take-home message on vaccines. And I think practically speaking, nobody really knows when they are going to be readily available. But I think probably the first part of 2021 is when we might have some deployable vaccines. From what I have read, the CDC is going to be responsible for allocating vaccines, and they're going to allocate them to states. And then the state health department is going to further allocate the vaccines. So just because they are available doesn't mean you can walk up to Walgreens and get a coronavirus vaccine. I think it's going to be sort of a long drawn out process. I have heard also that vaccines are going to be initially allocated to healthcare providers and then, maybe nursing home residents or elderly high risk people. But, honestly, what the CDC says changes almost weekly. So who knows in 4 or 5 months when we actually have vaccines ready to deploy, who's going to be able to get them and when. So that brings me back to really the take home message for the COVID pandemic is, don't go out, wear your mask, wash your hands. And, you'd think in the 21st century, when you can put a man on the moon, we'd have something more technologically advanced than that, but we don't. So that's all I had, all of the prepared remarks that I had. So I think Doug is going to wrap up.
Great. Thank you, Dr. Perry. Really appreciate that. We would love to open it up to some questions.
Yes, Donna. So we did get some questions in the chat feature during the presentation. This is for Dr. Lipton or Dr. Perry. Can you speak to the COVID testing process and when should you be tested and which tests would you recommend?
Beth, you want to take that one?
Yeah, I'll take that one. So people should be tested absolutely if they have symptoms of any kind. And so again, when testing was in short supply back in April, we were told that if you're young and healthy and you have COVID-like symptoms, suck it up and stay home. But now that the testing capacity has increased dramatically, I think anyone who has symptoms should absolutely get tested. Anyone who has an exposure to a known COVID positive person should absolutely get tested. But the key thing there is you have to wait really a minimum of 5 days after your last contact with the person if you were exposed to someone with COVID, because it does take a couple of days for the virus to multiply in your body to a level that's detectable. So if I was exposed yesterday and I ran right out today to get tested, odds are good that it would be a false negative because I just didn't wait long enough. And so I think anybody who's symptomatic or been exposed to people with known exposure should get tested. In terms of where to get tested, that's a little bit trickier in every area. The testing capacity is a little bit different. So the type of test right now, I prefer the PCR testing, which is the one done on either saliva or a nasal swab, because it's the most accurate. And so if you're getting the test, you want to get the right answer. And so the PCR testing can be done, the nasal swab testing can be done at CVS. You can make an appointment to drive up to a CVS to do that. LabCorp now has a test that you can order online yourself. It's called Pixel, Pixel. And it's not quite as deep a nasal swab as the nasopharyngeal, but you do that at home. So, for example, my daughter, who is at Clemson, was exposed to COVID about 2 weeks ago. And so she went online and ordered a test, a LabCorp test from Pixel, and she swabbed her own nose and mailed it back to them and got the result within about 36 hours. So there's lots of different options. So your regular doctor, a drive-up testing center, CVS, a mail order Pixel. You can order saliva tests online. You can order them from Vault Health or One Health, and they'll mail them to you. And the fee, which is $150, includes overnight postage in both directions. In order for most insurances are covering the nasal swab. The saliva test, maybe not so much because it's a little bit newer on the horizon, but the nasal swab covered by insurance. And right now, there's a federal law that insurance companies have to cover that with no out-of-pocket costs. So financially, the smarter move is to get a nasal swab done so that it can be billed to your insurance. And the Pixel one that I mentioned that's available by mail, they bill that to your insurance. So that's basically the testing situation.
Another question that we received is, does COVID behave like other viruses that tend to be seasonal? And does that mean that it will last longer than other types of viruses?
Well, I can take this. So that's something that, again, since we've only gone through 2 seasons with COVID, in this country at least, we don't know yet. What we're hoping, as Beth mentioned, we first of all don't know how long immunity is good for, if there even is immunity once you develop antibodies. And we also don't yet know the seasonality, because obviously it's gone through all 4 seasons. There seems, there was definitely a drop. There was a drop in cases from the spring, but that was since lockdown measures went into effect. So we don't know if that's due to COVID. We don't know if that's due to lockdown measures and social distancing and whatnot, and more attention to hygiene. I think it's just too early to tell. We'd have to go through at least a 2-year cycle before knowing the actual behavior of this virus. I should also mention, we don't know whether once there is a vaccine, how long immunity will be conferred, because if it is like the flu virus, which mutates from year to year or basically presents itself differently every year, does that mean that in every year we're going to need a new double shot series of COVID vaccine? That would of course be a bad case scenario, but it may be true, and that is determined by seasonality and mutation rates of the virus.
Another question that we received in the chat was, how do we build up our immune systems to decrease our chances of getting COVID and also of getting the flu?
Well, for the flu, you don't need to. I mean, you for both of these viruses, one of the most important determinants of outcome is your underlying health before you get it. So if you're a young, healthy person and you're not overweight, with no lung or heart problems, then you are much more likely to do fine. And of course, this sort of alludes to the fact that, as Beth mentioned, we know that there are a lot of people that are asymptomatic carriers. We don't know how many of them are asymptomatic carriers because they're asymptomatic. But it does appear that much of the asymptomatic carriage is in younger, healthier people. So the best way to make sure that you don't get sick from COVID, even if you do get it, the best way to make sure you don't get COVID is to stay away from people with COVID. The way to make sure you don't get sick from it if you do get it is to make sure your underlying health is good, that you're exercising, that you're eating right, that you're not overweight, because and of course that you're paying attention to any underlying illnesses like heart disease, lung disease, diabetes, and that sort of thing.
one other question that's particularly relevant.
Let me hold on one
for
sec.
myself.
Let me tack onto that real quick and just say, I think the point of the question there might have been, just taking vitamin C or using airborne or echinacea or something like that. There has never been any proof of scientific benefit from that. So at this point, there's not really a vitamin or a supplement that one can take to reduce one's risk of catching a viral infection.
Although I should say, with regards to COVID, there are reports from Italy and New York that there were observational studies that showed that people whose vitamin D levels were low were more likely to do poorly. That's vitamin D, but that doesn't mean that vitamin D is going to prevent COVID. It doesn't mean that it's going to prevent you from dying from COVID. But again, ensuring that your labs and your pre-existing health are in good order when it comes to things that we do pay attention to at annual physicals and whatnot. That's of key importance.
Should we continue to avoid indoor types of situations? And what are your thoughts regarding flying?
So we need to still avoid crowded areas indoors. Whatever can be done outdoors should be done outdoors, and masking should be encouraged. With regards to flying, again, we don't really know the true risk of flying, even though there have been some mathematical models proposed based on the prevalence of the disease in the United States. That one of these models suggested that in a fully loaded or full capacity 737 in the United States, for every hour of travel, assuming everybody on the plane is wearing a mask, which is a pretty big assumption to make because not everybody does. But if under that assumption, there's only about a 1 in 4,000 chance of contracting COVID for every hour of flight. But again, that's a mathematical model. So flying, especially to an area of high prevalence, it should be done cautiously because you're still walking through airports. That is just for the flying portion. What the airlines have done is they've increased airflow throughout the cabin because we do know that airflow does reduce the risk of getting the disease, basically, but it doesn't eliminate it 100%.
I've heard that there can be as much as a 3-week delay in getting the test results back. What could cause this?
So I'll take that question. So in July, we were seeing huge delays. 3 weeks is probably a little bit long. Huge delays in test resulting, and that's because of the capacity of the labs. So remember I said in order to run a nasal pharyngeal swab, you need a fancy piece of equipment. Hypothetically speaking, that piece of equipment can maybe only run 300 tests an hour. And if the lab gets 1,000 tests or 10,000 tests that day, it could take a long time for all of those to run. So capacity of space on machines on the analyzer was an issue back in July. And then there were reagent shortages. So a lot of the reagents that are used to extract the virus from the swab are manufactured in China and other countries. And so we didn't have the reagents. And so even if you had a spot on an analyzer to put a test, they didn't have enough reagents to run it. And so again, testing capacity has increased dramatically. So we're hoping that those shortages are behind us. But if we were to suddenly see, a quadrupling of number of samples sent to labs, then we would see delays again, I'm sure.
I'm going to put in a plug for Signature so even though we did experience some delays in July, we are the longest that any of our patients have had to wait for the test result was 5 or 6 days. And lately, ever since the middle of July, we've been for most of our testing, actually for most of our recommended testing, I should say, it's been less than 48 hours across the board.
That's impressive. And I know in my particular case, I tried to get testing here locally in Greenville, and it was going to take upwards of a week to actually get my results back. So having that quick turnaround as soon as 48 hours is really beneficial.
We've been very fortunate with our, sorry?
Sorry to interrupt. One final question that we had received was, how will telehealth play a role in preventative medicine?
Well, that's a difficult one because, of course, a lot of preventive medicine includes measures like vaccines, and in our case, we do an EKG and blood work and things like that. Obviously, telehealth cannot do blood work. Telehealth cannot do EKGs. Telehealth cannot do calcium scores or other cardiovascular risk stratification tests, but it's can't give vaccines. So there are definitely some shortcomings when it comes to virtual visits and telehealth. But if it's just a question of, for example, a doctor doing a follow-up for a wound, or a doctor doing a follow-up to discuss blood pressure or something like that, it's definitely useful for things like that. But it's not as useful for those annual health maintenance things like flu shots, and pneumonia shots for people over the age of 65 or people with lung conditions. It doesn't work for everything.
Great. Any additional questions?
Well, one, just because we touched on it there, any pointers on the heart health, since that is still by far the, way up there, even in relation to COVID numbers for most people, that you want to remind everybody of?
Well, obviously, making sure that your underlying risk factors for coronary disease, like diabetes, hypertension, and cholesterol issues. I'm hearing an echo. Making sure that all those things are in order is the most important thing. Obviously, you can't choose your parents, so family history you can't really control, but all those other ones you can. We're very much in favor of doing, or at least most of our physicians do some additional risk stratification, like advanced lipid testing, and in some cases calcium scores or carotid IMTs, or even CT angiograms, which is now the latest greatest technology for people with chest pain or high risk cardiovascular disease. It's still, like you say, cardiovascular disease is still a much bigger killer of Americans and causes more morbidity and mortality for Americans than COVID and all cancers combined.
I want to add one thing to that, and this is kind of boring and not very sexy, but to your point about cardiovascular disease is you have to take care of yourself. You have to eat right. You have to get regular exercise and don't smoke. It's really a simple formula. And to Jordan's point, everyone has a different hereditary risk for conditions such as diabetes and high cholesterol and high blood pressure. So the main thing to do is keep your weight down by eating a prudent diet and getting regular exercise, don't smoke, and then manage any chronic health conditions that you have as a result of heredity.
Great. Any other questions? Well, that was a great presentation. Lots of great information. Really appreciate you running us through the Concierge Medicine benefit, as well as our current environment with COVID, which of course is always changing, but very thorough and great questions as well. First, I'd like to thank those who have helped organize this event. Really appreciate all of that. Thank you, Will, for your great facilitation. And a very special thank you to our friends at Signature Healthcare, Dr. Lipton and Dr. Perry. Thank you for taking the time out of your busy day to share your insights and thought leadership in the field of medicine. Thank you for your partnership. We're happy to announce that Signature Healthcare will offer a membership discount to FinTrust clients, and we really appreciate that. As you know, health is paramount to our clients. And again, thank you for that. Thank you for those who participated today to take time out of your lunch break to be with us. And for those of you who are our clients, we are grateful for the trust that you place in us. And we hope that we see you at our next Break and Educate series. Thank you so much.
Thank you.